Good morning, this is Dr. Sonia here, and today my topic is mechanical ventilation complication and lung protective strategies. So the objective of my presentation, I would be talking on complication of having patient intubated, different types of ventilator-associated lung injury, and understanding the basic principles of lung protective strategy. So first off, let's look at the complication of having patient mechanically ventilated. So I've divided it into two categories, which is mechanical and physiological. So mechanical is the mechanical complications related to the presence of the ETT itself in the airway, and physiological is the complications related to positive pressure ventilation, infections that come about after a patient is mechanically ventilated, and ventilator-induced lung injury. So going to mechanical complication of intubation. So first off, we look at the complication that comes secondary to the ETT placement. So what can a patient get? They can get upper airway trauma, such as mucosal lacerations and hematoma, sore throat dysphonia and dysphagia, as well as tooth avulsion. This comes about when you press the laryngoscope blade too much pressure on the patient's tooth, and the patient's tooth end up getting avulsed. Tracheal stenosis is a common complication secondary to intubation, whereby there is a regional ischemic necrosis over the surrounding structure that is being compressed by the ETT tube. Laryngeal edema happens when you have large or overly inflated ETTs, especially when you use it for a prolonged time, and this can cause edema and ulceration over the laryngeal mucosa. Right main stem is a common complication when you have inserted the ETT way too deep into the airway and it goes only into the right lung. What can happen after that? The patient's only getting single lung ventilation, which is not optimal for the patient. Cuff failure is a common complication as well, whereby the ETT cuff, as you can see at the bottom of the ETT, is not adequately inflated. It's important for us to check our equipment prior to intubation. So before intubating a patient, make sure you try to inflate the cuff of the ETT first. If the balloon is not fully inflated, do not use the ETT. Discard it. The balloon has to be completely inflated so that there wouldn't be any air leak that is going to impair the ventilation of the patient. Next, we move on to the physiological complication of positive ventilation. So what are the unwanted effects of positive pressure? Let's look at the hemodynamics. What happened to our body post-intubation, post-positive pressure ventilation? So this positive airway pressure will be transmitted to the surrounding structures of the thorax. So there will be increase in intrathoracic pressure, which then will compress the pulmonary vascular bed, will cause increase in a pulmonary vascular resistance, which therefore reduces your right ventricular preload. So as you all know, physiologically, if the preload is reduced, afterload will be increased. So both this effect will then downsize your stroke volume and then lead to reduction in your cardiac output. What about the left ventricle? The left ventricle output will be reduced because there will be increase in pulmonary vascular resistance, which will cause a shift in the interventricular septum to the left. And this will then impair the left ventricular filling, especially during diastole, and further on lead to reduction in the cardiac output. So what happens to other organs when you have reduced cardiac output? Of course, there will be compromise. So what will be compromised first? Your splenic as well as your renal blood flow. So let's look at the gastric. So once there's reduction in the blood flow to the gastric, you start getting mucosal ulceration. In patients that are not mechanically ventilated, they have non-invasive ventilation, they start developing gastric distension. That is due to the large amount of air that is being swallowed when the air enters the body. So they develop into gut distension. So Regarding the decreased splenic perfusion, how can you detect it in a patient? So in some patients, it will manifest as elevated plasma aminotransferase and elevated LDH levels. Let's look at the renal. So they have said that mechanical ventilation is associated with development of acute renal failure. In a study done in 2005, they have noted that the renal injury occurs through the release of inflammatory mediators such as interleukin-6. And another postulated theory was due to the reduction in the cardiac output, there will be reduced in renal blood flow, and this leads to acute renal failure. Talking about CNS, how does CNS get affected from the positive pressure ventilation? So when the patient is mechanically ventilated, this positive pressure increases the intracranial pressure. How? From the raised intrathoracic pressure, it impairs your cerebral venous outflow. Most patients develop systemic muscular weakness due to the prolonged immobilization, prolonged use of sedatives, as well as using of neuromuscular blocking agents. So how do we overcome it? The goal is to early immobilization and exercise. So you got to get them referred to the rehab or physiotherapy to make sure that this patient will return to independent functional status as soon as possible after intubation. Let's look at the immune system. The positive pressure ventilation appears to induce inflammation. How? It amplifies the lung-specific inflammatory response by elevating the cytokine release and augmenting the alveolar integrity. This then promotes the translocation of bacteria into the bloodstream. So they've done a study in 1999 to compare if large tidal volume, lower PEEP versus lower tidal volume, higher PEEP. Which category of this promotes more inflammatory mediators? So the study have shown that larger tidal volume with lower PEEP promotes increased inflammatory mediators in the blood as well as bronchoalveolar lavage fluid. So other complications that you can see in patients who are mechanically ventilated are venous thromboembolic diseases. So that's why it's important for these patients to be started on their anticoagulant as early as possible. Some get TED socks for prevention of venous clotting at the venous system. Insulin resistance is quite common. As you can see, a lot of our mechanically ventilated patients are very dependent on the insulin infusion to stabilize their blood sugar in the blood. Joint contractions happen when the patient is having prolonged bed rest. So there's inadequate muscle movement, inadequate usage of the muscle, and this leads to joint contracture. And as we all know that prolonged immobilization, prolonged bed rest leads to formation of sacral sore as well as pressure ulcers. Moving on from the complication of positive pressure ventilation, next off we would be talking on infection related to mechanical ventilation. So very commonly these patients, they develop VAP, which is your ventilator associated pneumonia. And usually it develops 48 hours after patient is mechanically ventilated. So patient presents with signs of tachycardia, fever. In the ventilator, you may see that this patient receive reduced tidal volume and increased inspiratory pressures. In the lab findings, you may find that this patient tend to have persistent hypoxemia versus worsening leukocytosis in the full blood count. In the imaging, you may find that this patient starts getting new or progressive infiltrate on the chest x-rays. So what are the factors that increases the risk of VAP? Studies have shown that reduced salivary flow in a patient, pooling of subglottic secretions, and usage of systemic antibiotics can cause increased risk of VAP. So they have come up with the prevention method, which is called the Care Bundle for Ventilator-Associated Pneumonia Prevention. So there are 4 elements here, which is first, elevating the head up to 30 to 45 degrees. This is to prevent aspiration. When the patient is lying supine, they have tendency to aspirate on their gastric as well as their oropharyngeal contents. So you tend to elevate their head up to prevent this aspiration from happening. Spontaneous breathing trial or spontaneous awakening trial is one of the other elements that prevents VAP from occurring, whereby, as we know, that sedation is used to ensure that our patients are comfortable during intubation. So when sedation is reduced, you have to evaluate if your patient is ready to be weaned or extubated. So if they are ready, if they can tolerate extubation, then you tend to extubate this patient. So what you reduce their number of days of patient having mechanically ventilated, and this therefore reduces the risk of getting VAP. Subglottic secretion drainage and making sure the tube cuff pressure more than 20 cm water is another part of element to reduce the risk of VAP. As we know, the spooling of subglottic secretions surrounding the ETT cuff will promote the presence of our pathogens, and this can increase the risk of VAP. So you got to make sure that adequate suctioning is done to prevent this accumulation of subglottic secretions. Changing of ventricular tubing and suction system only when clinically indicated. Why? Because frequent manipulation of the tubing will cause contamination of the secretion to enter our bronchial tree via the ETT lumen. So you only need to change the the tubing when you see visible soiling or when it's faulty. Alright, and this have been proven in various studies where it reduces the VAP as well as your cost. So in addition to the VAP bundle in the 4 elements that I've mentioned earlier, you got to make sure that our patients get oral and gastric decontamination as well, which is using chlorhexidine mouthwash to prevent oral contamination and probiotics for gastric decontamination. Studies have advocated that using conservative fluid management is a way to go to prevent VAP from occurring, whereby you don't want to simply flood the lungs, and this can create room for bacteria to grow. Conservative transfusion of blood products is advocated because you don't want foreign bacteria to enter the bloodstream. Deep venous thrombosis prophylaxis is another recommendation to prevent VAP. Very importantly, the basic recommendation would be your hand hygiene and wearing PPE every time when we are in contact with the patient. And lastly is avoiding gastric distension. Over distension is another element for VAP bundle. So this is a table of all the elements that I've mentioned above that I got in up to date. And from the intervention, you can see the list of quality of evidence from the intervention. So what are high evidence recommendation? Of course, if you don't, if the patient is not invasively ventilated, they are just using non-invasive pressure ventilation, they tend to get lower risk of getting VAP. As you can see, as I mentioned earlier, interrupting sedation daily, assess the readiness to extubate daily, perform spontaneous breathing trial with the sedation turned off. These are all high evidence of recommendation in preventing VAP from occurring. And lastly, changing the ventricular circuit only if it's visible, when the soil is visible or when it's malfunction, is also one of very high evidence of preventing ventilator-associated pneumonia. Next, we move on to pulmonary complication, which is your ventilator-induced lung injury. So there are 6 types of lung injury that can happen from your ventilator. The first off is volutrauma, which is defined as overdistension of normal alveolar units to transpulmonary pressure more than 30. Biotrauma, which is a tissue disruption that leads to release of chemokines and cytokines, which later on leads to SIRS and MODS. Barotrauma happens when you have increased transpulmonary pressure more than 50 cm water that causes the disruption of basement membrane. Athalec trauma occurs when there is repeated alveolar collapse and expansion with tidal ventilation, which can cause lung injury. Shearing injury occurs at the junction of ventilated lung and collapsed lung. So when the ventilated lung is moving against the relatively fixed collapsed lung, it will lead to high shearing force, and this can lead to shearing injury. Oxygen toxicity happens when you have higher than necessary FiO2, which will overcome the cell's ability to deal with the free oxygen radicals. So from this pulmonary complication, you must develop your lung protective strategy to prevent this pulmonary complication from happening. But before knowing your lung protective strategy, you must understand the pathology that you're dealing with. Is it an acute lung injury or is it a ARDS? So for acute lung injury, it has to be acute onset. Your PF ratio is less than 300, and you can see bilateral infiltrates consistent with pulmonary edema. But this pulmonary edema must be not influenced by LA hypertension, which is your cardiogenic cause, cardiogenic heart failure. And next we look at ARDS. ARDS is acute onset, PF ratio less than 200, and your bilateral infiltrates consistent with pulmonary edema. And same as acute lung injury, this bilateral pulmonary infiltrates must not be influenced by the cardiogenic pulmonary edema. So the difference between these two is just the PF ratio value, which is 1, ALI is less than 300, and ARDS is less than 200. So moving on to the goals of lung protective strategies. Number 1, you want to make sure that there is low tidal volume. Why low tidal volume? Because you don't want to overinflate the good lung and cause injury. This is to prevent your volutrauma, barotrauma, and biotrauma. As you can see, in the ARDS patients, they tend to have limited lung availability for ventilation. That is called the baby lung, which means that they only have very few lung capacity left for ventilation that is functioning. All right, the rest is all gasless compartment. So you don't want to simply add on a large amount of tidal volume or a normal tidal volume, because you know that you're going to overexpand the only baby lung left in this patient. Okay, so the target would be 6 cc per kg or less of the ideal body weight. Next off, we look at limiting the plateau pressure, which is less than 30 mm mercury. Plateau pressure is also known as P-plat, and it's defined as your alveolar distending pressure, which correlates to your lung compliance. So too high of a P-plat may cause barotrauma and valvular trauma. So the goal would be to making sure your P-plat is less than 30 mm mercury to prevent barotrauma, which is your pneumothorax. The way to obtain your P-plat would be by pressing your inspiratory pause in your ventilator. Alright, and you got to make sure that your patient is adequately sedated before you do this maneuver. Next, we look at getting the optimal PEEP. This is to prevent your athalec trauma. So as we all know, PEEP is protective. So during expiration, this alveoli, the PEEP makes sure that the alveoli do not collapse during expiration, and this therefore will maintain adequate alveolar surface area for adequate oxygen diffusion to continue. So if you can imagine this, the lung equals to like a balloon, okay? So at the end of inspiration, you will have an inflated balloon, and from inspiration you proceed into expiration phase. So you for PEEP, usually at the end of expiration, you want to have a remaining alveoli that is open rather than a collapsed alveoli, because open alveoli will provide more alveolar surface area for facilitating the oxygen diffusion, and you will need a less pressure required to expand the lung in the next breath. So but you got to keep in mind that the functional lung size, as I mentioned earlier, is actually smaller than expected, because these patients tend to have lung pathologies like atelectasis, consolidation, Buloh, effusion, or fibrosis. So the decreased availability of the lung for ventilation will manifest as decrease in compliance. So previously, in year 2000, we used to talk about ARDS Net Protocol, which means that, okay, once you have a patient who fulfill your inclusion criteria of ARDS, okay, you start up the ventilator with the adjustment given, and then your goal for ventilation would be PaO2 55 to 80 and saturation 88 to 95%. And the thing that you will be adjusting would be your PEEP and FiO2. So they have a table here where you just you tend to follow what is the given PEEP and what's the FiO2. So you only adjust looking at the PEEP and FiO2 to maintain the adequate ventilation. This is a traditional way of managing ARDS, and the goal is just to make sure the P-plat is less than 30. However, as years pass, they have come up with new studies, and they mention that this ARDS net does not take account of the proportion of the lung that is not available for ventilation. So in 2015, there is a new study done by Amato et al. He start mentioning on the measuring the driving pressure, because this driving pressure is best relates to the patient outcome. So how to get driving pressure? The formula is driving pressure equals to tidal volume divided by the compliance. So the lower the compliance, the higher the driving pressure. But in reality, it's quite difficult to measure compliance in the ventilator. So they have simplified the formula, and they come up with a new formula, which is driving pressure equals to P plateau minus the PEEP. So over-distending or under-ventilating atelectroma, the lung, beyond the functional size would increase the driving pressure. So when you want to have optimal PEEP, you got to have an reduced driving pressure. Then you can minimize the barotrauma. So the goal of driving pressure is less than 15, but the lower the better. So as you can see here, the table, the mortality is reduced when you have reduced driving pressure, and the target is less than 15. So how to calculate an optimal PEEP? So first off, you have patient ventilated in front of you. Okay, you set the PEEP to 8 and you measure the P-plat. Okay, the ventilator shows you now the P-plat is 25. So you get the driving pressure is by minusing P-plat minus PEEP. 25 minus 8 is 17. So the driving pressure for this patient is 17. And it's still high than what you have to give to the patient. So what you do is you increase the PEEP to 10. Next, measure the P-plat. What's the P-plat now? The P-plat is 26. So what's the new driving pressure? 26 minus 10, which is 16. 16 is still high for your patient. Remember, your aim is less than 15. So you increase the PEEP. As long as your PEEP plat is less than 30, you may increase your PEEP. So your PEEP is now 12, your PEEP plat is 26, your new driving pressure is 26 minus 12, which is 14. Okay, keep it that way. Can you increase again? Because you want to get lower driving pressure, right? So you increase again the PEEP to 14, but this time the PEEP plat goes up to 31, and your driving pressure at this point is 17, which is 31 minus 14. So is this optimal? No, because your driving pressure has exceeded the limit. So this would be our, by increasing the PEEP to 12 and the PEEP plat to 26 would be our optimal PEEP. Other lung protective strategies are minimizing oxygen toxicity, that is so that your body can fight the free radicals. Permissive hypercapnia is another part of lung protective strategy. There's no defined level of CO2 for hypercapnia. The studies advocated that as long as the pH is more than 7.2 is good enough for the patient. However, you must understand there are certain contraindications to allow permissive hypercapnia, which is increased ICP, hemodynamic instability, right heart failure, and severe metabolic acidosis. Permissive hypoxemia, as I mentioned earlier, you may allow PaO2 more than 55 with a saturation of more than 89%. So this is a diagram that summarizes the therapy options in ARDS. Number one, as we always do in our ED, would be proning, where you want to reduce the pleural pressure gradient and you want to improve the VQ mismatch. Paralytic agents, we do give our patients who are mechanically ventilated because you want to improve the patient ventilator synchrony and you minimize the muscle oxygen consumption. And lastly, your lung protection strategies, as I mentioned earlier, in summary, you have to use low tidal volume, which is 4 to 8 cc's per kg, ideal body weight. Make sure the PEEP plat less than 30, titrate the PEEP to open a collapsed lung, and make sure, never forget to calculate the driving pressure and make it less than 15 cm water. Okay, with that, I end my topic for today. Thank you. These are my references. Thank you.